ECA hospital setting, what is the role of a pharmacist in preventing medication errors during the prescribing and dispensing process? Discuss specific strategies that a pharmacist can employ to reduce these errors and ensure patient safety. Answer: pharmacists play a critical role in preventing medication errors by employing several strategies during both prescribing and dispensing processes. These include medication reconciliation. Pharmacists ensure that medication histories are accurate and complete when patients transfer between care settings, reducing the chance of errors. Double check system. Implementing a system where pharmacists verify prescriptions and conduct a second check during dispensing helps catch potential errors. Use of technology. Automated dispensing cabinets, barcoding systems, and electronic health records aids help pharmacists verify dosages and avoid errors associated with manual handling. Clear communication. Pharmacists should clarify any ambiguous or incomplete prescriptions with the prescribing physician to avoid misinterpretations. Counseling patients. Providing patients with detailed counseling about their medications, including dosage, administration routes, and potential side effects, reduces the likelihood of errors occurring after dispensing. Relevant guidelines. The Institute for Safe Medication Practices outlines best practices for preventing medication errors, emphasizing the use of technology and effective communication between healthcare providers. Mr. Rodriguez, a pharmacist in a busy community pharmacy, notices that a prescription for a pediatric patient includes an unusually high dose of an antibiotic. The prescription was written by a new physician who is unfamiliar with pediatric dosing protocols. What steps should Mr. Rodriguez take in this situation to ensure patient safety? Answer: in this situation, Mr. Rodriguez should verify the prescription. Before dispensing the medication, Mr. Rodriguez should contact the prescribing physician to verify the dosage, especially since pediatric dosing is often weight-based and errors in pediatric prescriptions can be fatal. Cross-check resources. He should consult dosing guidelines, such as the Lexicon Pediatric and Neonatal Dosage Handbook, to confirm the appropriate dose for the patient's age and weight. Document the verification. After clarifying with the physician, Mr. Rodriguez should document the interaction and the correct dose in the patient's record to ensure that any future prescriptions are accurately based on the patient's medical history. Counsel the patient's caregiver. It is essential to explain the correct dosage and administration to the caregiver and ensure they understand the instructions, especially for pediatric patients where dosing precision is crucial. Relevant guidelines. California Business and Professions Code SS4051 requires pharmacists to exercise professional judgment in verifying prescriptions and protecting patient safety. Explain the pharmacist's role in antimicrobial stewardship within healthcare settings. Why is this important for infection control, and what are some key strategies pharmacists use to promote appropriate antimicrobial use? Answer: pharmacists are integral to antimicrobial stewardship programs (ASPs), which aim to optimize the use of antimicrobials, reduce resistance, and improve patient outcomes. Their roles include reviewing prescriptions. Pharmacists ensure that antimicrobial prescriptions are appropriate in terms of drug selection, dosage, duration, and route of administration based on culture and sensitivity results. Monitoring for resistance. They track antimicrobial resistance patterns and provide data to the healthcare team to guide empirical therapy choices. Education and policy development. Pharmacists educate healthcare providers and patients about appropriate antimicrobial use and assist in developing hospital policies to reduce unnecessary antibiotic use. De-escalation therapy. Pharmacists review therapy once culture results are available, recommending discontinuation or switching to a narrow-spectrum antibiotic if appropriate. Relevant guidelines. The Centers for Disease Control and Prevention (CDC) offers guidelines on antimicrobial stewardship, emphasizing the role of pharmacists in curbing antibiotic resistance. What are the key components of a continuous quality improvement (CQI) program in a pharmacy, and how does it help ensure medication safety and patient care? Answer: a CQI program in pharmacy involves ongoing efforts to improve processes and reduce medication errors. Key components include data collection and analysis. Pharmacies collect data on medication errors, adverse events, and near misses to identify trends and areas for improvement. Root cause analysis. When errors occur, pharmacies conduct root cause analyses to determine underlying issues and implement corrective actions. Staff training. Ongoing education and training ensure that staff members are aware of best practices in medication safety. Patient feedback. Gathering and incorporating feedback from patients helps identify potential safety risks in pharmacy operations. Implementation of best practices using evidence-based strategies, such as checklists or automated systems, improves accuracy and reduces the likelihood of errors. Relevant guidelines. The National Association of Boards of Pharmacy (NAP) sets standards for CQI programs which are required under California Business and Professions Code SS4125 for pharmacies to monitor and improve medication safety. Ms. Patel, a pharmacist in a retail pharmacy, receives a shipment of medications and notices that a batch of insulin has been recalled. She also finds that some of the stock is close to expiration. What steps should Ms. Patel take to comply with regulations regarding drug recalls and expired medications? Answer: Ms. Patel should identify and isolate the recalled medications. She must immediately remove the recalled insulin from the shelves and quarantine it to prevent dispensing. Notify affected parties. Following the recall notification procedure, she should inform patients who may have received the recalled product and advise them on proper steps, such as returning or discontinuing use. Document the recall process. She should document all actions taken, including notifications sent to patients and the proper disposal of the recalled product. Proper disposal of expired medications. For the stock close to expiration, Ms. Patel should ensure these are removed and disposed of in accordance with California State Board of Pharmacy regulations, which may include returning them to the supplier or using a certified medication disposal program. Relevant guidelines. California Health and Safety Code SS117600118360 outlines the proper disposal of expired or recalled medications, while the FDOS recall procedures should be followed to manage drug recalls effectively. What are the key differences between a Class I, Class II, and Class II drug recall, and how should a pharmacist respond to each class? Answer: the FDA classifies drug recalls into three categories based on the severity of the health hazard. Class I recall: the most serious, where the product poses a significant risk of serious health consequences or death. Pharmacists must immediately stop dispensing the product, notify patients and healthcare providers, and follow recall protocols promptly. Class I recall: products may cause temporary or medically reversible adverse health effects, but the risk is less severe. Pharmacists still need to remove the product from stock and notify patients, but the urgency is lower than for Class I recalls. Class II recall: products are unlikely to cause adverse health effects but violate FDA regulations, e.g. labeling errors. Pharmacists should still remove these products but do not need to issue patient notifications unless otherwise instructed. Relevant guidelines. FDA 21 CFR 7.3 details the classification of recalls and provides guidance on actions that pharmacists must take for each type of recall. Discuss the pharmacist's responsibility in handling expired or unused medications. How does the pharmacist ensure compliance with regulations regarding medication disposal? Answer: pharmacists are responsible for the safe disposal of expired or unused medications to prevent environmental contamination and drug diversion. Steps include compliance with drug take-back programs. Pharmacists should inform patients about local drug take-back programs or in-pharmacy disposal services, ensuring compliance with DEA and PA regulations. Use of reverse distribution systems. Pharmacies often employ reverse distributors to handle expired medications in compliance with California Code of Regulations, Title 16 SS 1718. Secure storage. Expired medications should be stored securely until they can be disposed of through certified hazardous waste disposal companies to prevent unauthorized access. Relevant guidelines. The Drug Enforcement Administration regulates the disposal of controlled substances under the Secure and Responsible Drug Disposal Act. Dr. Lee prescribes a medication for a patient with known allergies. Upon review, the pharmacist, Ms. Carter, notices the prescribed drug is contraindicated due to the patient's allergy. What steps should Ms. Carter take to ensure patient safety? Answer: Ms. Carter should verify the allergy information, review the patient's medical record to confirm the allergy and assess the severity of past reactions. Contact the prescriber. She should immediately notify Dr. Lee about the contraindication and recommend an alternative treatment. Document the interaction. The conversation and decision to switch or not dispense the medication should be documented in the patient's profile. Counsel the patient. If the medication is changed, Ms. Carter should ensure the patient is aware of the reasons for the change and any new instructions. Relevant guidelines. California Business and Professions Code SS4052 outlines pharmacists' authority to consult with prescribers and intervene in cases where patient safety is at risk due to prescription errors. Explain the process of risk management and mitigation in pharmacy practice. How can pharmacists proactively reduce the risk of medication errors? Answer. Risk management in pharmacy practice involves identifying, assessing, and mitigating potential risks associated with medication dispensing and patient care. Pharmacists can reduce risk by implementing standard operating procedures SOPs guide pharmacy operations, ensuring consistency and reducing human error reporting systems. Establishing a non-punitive medication error reporting system encourages staff to report errors and near misses, which can be analyzed to prevent future occurrences. Regular training, continuous staff education on medication safety protocols helps maintain awareness of best practices. Use of technology, electronic prescribing, barcode verification, and automated dispensing systems reduce human error. Relevant guidelines. The Institute for Safe Medication Practices provides recommendations for risk mitigation strategies, including technology integration and error reporting systems. What accreditation standards, such as those by the Joint Commission, are relevant to pharmacists, and how do they influence pharmacy practice? Answer. The Joint Commission sets accreditation standards that influence various aspects of pharmacy practice, including medication management, The standards require pharmacies to have policies for medication storage, prescribing, dispensing, and monitoring. Patient safety goals. Pharmacists must comply with goals related to the prevention of medication errors, such as improving the accuracy of patient identification and ensuring the safe use of medications. Infection control. Pharmacists must participate in infection prevention efforts, such as antimicrobial stewardship programs and safe handling of medications. Relevant guidelines. The Joint Commission's comprehensive accreditation manual outlines the standards pharmacies must meet to ensure quality care and patient safety. According to USP 797, what is the proper sequence for donning personal protective equipment (PPE) when preparing sterile compounded products? Answer. The proper sequence for donning PPE in accordance with USP 797 guidelines is critical to maintaining aseptic conditions during sterile compounding. The correct sequence is as follows: shoe covers, placed before entering the cleanroom or buffer area. Head cover, covers all hair and facial hair if applicable. Face mask, covers the nose and mouth. Gown, sterile gowning occurs before entering the cleanroom. Hand hygiene. Hands must be thoroughly washed with antimicrobial soap and water. Sterile gloves. Sterile gloves are donned inside the cleanroom, ensuring that the gloves are regularly disinfected with sterile 70% isopropyl alcohol during compounding. These steps are crucial in minimizing contamination risks while maintaining sterility in the preparation of IVIM and SC formulations as mandated by USP 797. Explain the key principles of the USP 800 guidelines regarding the handling of hazardous drugs in a compounding pharmacy. Answer. The USP 800 guidelines provide comprehensive standards for the safe handling of hazardous drugs (HDS) to protect healthcare workers, patients, and the environment. Key principles include designated areas. Pharmacies must have designated areas for compounding and storing hazardous drugs. These areas must be separate from non-hazardous drug preparation areas and properly ventilated. Engineering controls. The use of containment primary engineering controls, CPECs, such as biological safety cabinets, BSES, or compounding aseptic containment isolators, CASIS, is required to minimize the risk of HD exposure. PPE requirements. Pharmacists and technicians must wear appropriate PPE, including gloves, gowns, eye protection, and respiratory protection if needed when handling HDS. Environmental monitoring. Regular wipe sampling is recommended to detect any contamination in HD preparation and storage areas. Deactivation, decontamination, and cleaning. Specific procedures must be in place for the deactivation, decontamination, and cleaning of surfaces exposed to hazardous drugs. This reduces the risk of cross-contamination and exposure. A compounded sterile product, CSP, was prepared in a non-compliant sterile environment. Based on USP 797, what is the risk level of this product and what is the maximum beyond use date, BUD, that should be assigned? Answer. According to USP 797, compounded sterile products, CSPS, prepared in a non-compliant or unclassified sterile environment are considered high risk. For high-risk CSPS, the risk of contamination is elevated due to the non-sterile preparation conditions. The maximum BUD for high-risk CSPS is determined as follows: room temperature, 24 hours refrigerated, 3 days frozen, 20 or colder, 45 days if sterility testing has not been conducted. The CSP must be used within these time frames to minimize the risk of patient harm due to microbial contamination. Dr. Patel has prescribed a total parenteral nutrition (TPN) formulation for a patient with severe malnutrition. The TPN order includes 25% dextrose, 4% amino acids, and 3% lipids. As the pharmacist, you are tasked with preparing this sterile product. How would you ensure the correct preparation and avoid precipitation of the TPN components? Answer: to avoid precipitation and ensure correct preparation, the pharmacist must follow these key steps. Order of mixing: the components should be mixed in a specific order to prevent compatibility issues. The recommended sequences: add the dextrose to the base solution first, follow with the amino acids. Finally, add the lipids as the last component. Calcium phosphate solubility: to avoid calcium phosphate precipitation, it's crucial to monitor the final concentration of calcium and phosphate in the solution. Factors such as temperature, pH, and amino acid concentration can influence the risk of precipitation. Using calcium gluconate instead of calcium chloride can help reduce the risk of precipitation. Sterility: ensure proper aseptic technique as required by USP 797. The preparation should take place in a certified ISO Class 5 environment, such as a laminar airflow hood. Visual inspection: after mixing, the pharmacist should visually inspect the TPN for any signs of particulate matter or precipitation before dispensing. BUD assignment: based on the sterility conditions and USP guidelines, the pharmacist should assign an appropriate beyond use date, BUD, typically no more than 24 hours at room temperature if prepared under medium risk conditions. What are the labeling requirements for compounded sterile products (CSBS) according to USP 797? Answer: USP 797 mandates that compounded sterile products (CSBS) have specific labeling requirements to ensure patient safety. These include patient information, name, identification number, and any relevant demographic information, drug name and strength, full name of the active ingredient, concentration and dosage form, volume, total volume of the preparation, route of administration, clearly state the intended route, Romana M, SC, etc. BUD, the beyond use date based on risk level and storage conditions, storage instructions, specific temperature or light protection instructions, pharmacist verification, a space for the pharmacist to sign or initial indicating that they have verified the product for accuracy, warnings if applicable, any applicable warnings, e.g. for intravenous use only. This labeling ensures that CSPS are dispensed safely and with accurate information regarding administration and storage. During the preparation of a sterile compound, what are the essential environmental monitoring practices that a pharmacy must implement according to USP 797? Answer: USP 797 provides specific guidelines for environmental monitoring to ensure that the compounding environment remains sterile and safe for the preparation of compounded sterile products (CSBS). The essential monitoring practices include air quality monitoring. Pharmacies must perform routine air sampling in the sterile compounding area, including the buffer room and anteroom. This involves both active and passive air sampling methods. Active air sampling: use of air samplers to collect viable microorganisms in the air during operations. Passive air sampling: exposure of settled plates for a specified time to capture airborne microorganisms. Surface monitoring: regular surface sampling is crucial to detect contamination on surfaces within the compounding area. This involves using contact plates or swabs to test surfaces such as countertops, equipment, and compounding areas. Samples should be taken after cleaning and before compounding sessions. Personnel monitoring: staff must undergo routine monitoring to ensure compliance with aseptic techniques and to minimize the risk of contamination. This includes monitoring glove and gown samples to identify microbial contamination from personnel. Temperature and humidity monitoring: continuous monitoring of temperature and humidity levels within the sterile compounding environment is critical. Variations in these conditions can impact microbial growth and the stability of CSBS. Pharmacies should have calibrated monitoring equipment that provides real-time alerts for deviations. Documentation and corrective actions: all monitoring results must be documented, and any deviations from acceptable limits should trigger immediate corrective actions. These actions may include recleaning areas, retraining staff, or evaluating equipment maintenance. Ms. Thompson, a pharmacy technician, is tasked with preparing a compounded topical ointment using a semi-solid base. The physician has prescribed a formulation that includes a specific active ingredient and requires precise dosing. What steps should Ms. Thompson follow to ensure proper compounding and labeling of the ointment? Answer: Ms. Thompson must take the following steps to ensure the proper compounding and labeling of the topical ointment. Review the prescription. MS. Thompson should carefully review the physician's prescription to understand the required active ingredient, concentration, and total quantity to be compounded. She should confirm that she has all necessary ingredients and materials, including the semi-solid base. Follow USP 795 guidelines. Since this is a non-sterile compound, she must adhere to USP 795 guidelines, which include ensuring that the workspace is clean and free from contaminants. She should prepare the ointment in a designated compounding area. Weighing and measuring. Using an electronic balance MS. Thompson must accurately weigh the active ingredient. Precision is critical in ensuring the ointment contains the correct dosage. If using multiple ingredients, she should measure each component based on the formulation's requirements. Preparation techniques MS. Thompson should follow appropriate preparation techniques for ointments. This typically involves mixing, incorporating the active ingredient into the semi-solid base using a mortar and pestle or an ointment slab, homogenizing, ensuring that the active ingredient is evenly distributed throughout the base. Labeling requirements. Once the ointment is prepared MS, Thompson must label the product according to regulatory requirements. The label should include patient's name and identification, product name and strength, directions for use, beyond use date, but based on the stability of the ointment, storage conditions. What are the potential risks associated with compounding sterile products, and how can pharmacists mitigate these risks according to USP 797? Answer. Compounding sterile products (CCPS) present several risks that pharmacists must recognize and manage effectively to ensure patient safety. The risks and their mitigation strategies according to USP 797 include microbial contamination. One of the primary risks is microbial contamination, which can lead to severe infections. To mitigate this, pharmacists must work in a controlled environment, utilizing primary engineering controls (PECs), such as laminar airflow hoods that maintain sterility. Regular environmental monitoring, air and surface sampling is also essential to identify potential contamination sources. Non-sterile compounding. Preparing sterile products in non-sterile conditions can introduce contaminants. Pharmacists must adhere strictly to the cleanroom protocols outlined in USP 797, ensuring that all surfaces are cleaned and disinfected regularly and that personnel follow strict gowning and hand hygiene procedures. Incorrect formulation. Errors in compounding formulations can occur due to miscalculations or improper techniques. Pharmacists should implement double-check systems and standard operating procedures (SOPs) to ensure accuracy in ingredient measurements and formulation steps. Training and competency assessments for compounding personnel can also reduce the likelihood of errors. Improper storage conditions. Sterile products may degrade if not stored correctly, leading to compromised potency and efficacy. Pharmacists must ensure proper labeling and storage conditions following temperature and humidity requirements specific to each CSP. Regular checks of storage areas are critical to maintaining the integrity of the products. Extended beyond use dates, BUNS. Assigning inappropriate BUES can expose patients to ineffective or unsafe products. Pharmacists should base BUD assignments on stability data and the specific characteristics of the compounded product, adhering to the guidelines provided in USP 797 regarding high-risk and low-risk CSPs. What are the critical differences between sterile and non-sterile compounding practices is outlined by USP 795 and USP 797. Answer. The United States Pharmacopoeia provides distinct guidelines for sterile compounding USP 797 and non-sterile compounding USP 795, reflecting the different levels of risk and practices involved. The critical differences include environment. Sterile compounding USP 797 requires a controlled environment, specifically an ISO Class 5 air quality area, to prevent microbial contamination. This typically involves the use of laminar airflow workbenches or compounding aseptic isolators. Non-sterile compounding USP 795 allows for compounding in a general pharmacy setting, provided that the area is clean and free from contaminants, equipment, and techniques. Sterile compounding involves the use of specialized equipment such as aseptic hoods, and all compounding procedures must be performed under sterile conditions. Non-sterile compounding utilizes standard compounding equipment, e.g., mortars, pestles, mixers, without the need for sterile techniques. The focus is more on the proper preparation and mixing of ingredients rather than maintaining sterility. Documentation and training. Sterile compounding requires rigorous training and ongoing competency assessments for all personnel involved in sterile preparations. Extensive documentation is required, including environmental monitoring, records, and detailed logs of the compounding process. Non-sterile compounding. While documentation is important, the requirements are less stringent. Personnel must still be trained, but the focus is on basic compounding practices rather than sterile techniques, risk levels, and buds. Sterile compounding. Products are classified into risk levels, low, medium, and high, which determine the beyond use date, BUD, based on the potential for contamination. High-risk products have shorter BEDS due to the increased risk of microbial growth. Non-sterile compounding. BEDS are determined by the type of formulation and its stability, but the risk of contamination is generally lower than for sterile products. A pharmacist is working in a community setting and is approached by a patient who expresses interest in quitting smoking. The patient currently smokes 20 cigarettes a day and has tried quitting multiple times using nicotine replacement therapy (NRT), but with little success. The pharmacist wants to offer the most effective smoking cessation strategy. What would be the most appropriate evidence-based intervention for this patient? Answer: for a patient who has tried NRT without success, a combination therapy approach would be most effective. According to evidence-based guidelines, combining long-acting NRT, such as a nicotine patch, with a short-acting form, such as nicotine gum or lozenges, increases the chances of success. Additionally, the pharmacist could recommend a prescription medication such as varenicline or bupropion, as these have been shown to improve quit rates. Behavior modification strategies, including motivational interviewing and setting a quit date, should also be part of the intervention. The pharmacist must also be mindful of monitoring for any contraindications related to the patient's medical history, such as underlying mental health conditions that could be exacerbated by bupropion. Guidelines. According to the U.S. Public Health Service guidelines, combining nicotine replacement therapy and behavioral support leads to higher quit rates than using either intervention alone. Sarah, a pharmacist working in a hospital, is called upon to assist in an emergency situation involving a natural disaster that has left hundreds of individuals displaced and without access to their regular medications. One patient approaches Sarah stating that they are on insulin for diabetes and have no access to their medication. The patient does not remember the exact type of insulin they were taking. What should Sarah do in this situation? Answer: Sarah should assess the patient's condition, focusing on symptoms of hypoglycemia and any immediate medical needs. As the patient does not recall the type of insulin, Sarah should use her knowledge of insulin types and their action profiles. A reasonable course of action would be to initiate a basal insulin such as glargine or ditemir at a conservative dose to cover baseline needs, as these are long-acting and can minimize the risk of hypoglycemia. Additionally, regular monitoring of blood glucose levels would be essential, adjusting the insulin regimen as needed. In this emergency, collaboration with medical staff to obtain a prescription for insulin and providing education on blood glucose monitoring would be vital. Relevant law. According to California's pharmacy law, in a state of emergency, pharmacists are permitted to furnish medications without a prescription when a patient's life or health is at risk and regular medical services are unavailable. In response to the opioid crisis, a hospital pharmacy is implementing an opioid stewardship program. What are three core components of an effective opioid stewardship program, and how can the pharmacist contribute to each? Answer: monitoring and surveillance. Pharmacists should use prescription drug monitoring program (EDMPS) to track opioid prescriptions, identify patterns of misuse, and flag patients who may be at risk for opioid dependency. Regular audits of opioid use in the hospital setting can also help in adjusting prescribing habits. Education and training. Pharmacists should provide education to both prescribers and patients on the risks of opioid use, proper dosing, and non-opioid alternatives. They should also be involved in training healthcare professionals on safe opioid prescribing practices. Interventions for high-risk patients. Pharmacists can identify patients at high risk for opioid misuse and initiate interventions such as offering naloxone for overdose prevention or referring patients to medication-assisted treatment (MAT) programs for opioid use disorder. Guidelines. According to CDC guidelines for prescribing opioids for chronic pain, non-opioid therapies should be considered first, and opioids should be prescribed at the lowest effective dose when necessary. David, a community pharmacist, is approached by a concerned family member of a patient who is on high-dose opioid therapy for chronic pain. The family member wants to know more about naloxone and whether it would be appropriate for the patient. What should David advise? Answer: David should educate the family member on the importance of naloxone as a life-saving medication in the event of an opioid overdose. Given that the patient is on high-dose opioids, they are increased risk for overdose, particularly if there is any escalation in dose or the use of other CNS depressants, such as benzodiazepines or alcohol. David should recommend naloxone and provide training on how to recognize the signs of opioid overdose, e.g., respiratory depression, unconsciousness, and how to administer the medication. Additionally, David should inform the family member that naloxone is available without a prescription in California and is covered by most insurance plans. Law. Under California's naloxone standing order, pharmacists are permitted to furnish naloxone without a physician's prescription and are required to provide education on its use. A patient has been diagnosed with opioid use disorder and is interested in starting medication-assisted treatment. MAT. What are the three primary medications used in MAT for opioid use disorder, and how do they differ in terms of mechanism and patient suitability? Answer. Methadone. A full opioid agonist, methadone is dispensed in federally regulated opioid treatment programs. It works by reducing cravings and withdrawal symptoms while blocking the euphoric effects of other opioids. Methadone is suitable for patients who require a structured setting and may benefit from daily supervision. Buprenorphine. A partial opioid agonist, buprenorphine provides similar benefits as methadone but has a ceiling effect, reducing the risk of overdose. It can be prescribed by certified physicians and is often more accessible for patients who want greater flexibility in their treatment. Naltrexone. An opioid antagonist, naltrexone blocks the effects of opioids and is used for relapse prevention. It is suitable for patients who have already detoxed from opioids and are committed to abstinence, as it requires a period of opioid-free status before initiation. Guidelines. The Substance Abuse and Mental Health Services Administration (SAMHSA) provides evidence-based guidelines recommending MAT as the most effective treatment for opioid use disorder. What are some key strategies pharmacists can use to identify potential prescription drug misuse in patients, and what steps should they take when misuse is suspected? Answer. Pharmacists should look for red flags such as frequent early refill requests, prescriptions from multiple providers, or signs of intoxication or withdrawal when visiting the pharmacy. When prescription drug misuse is suspected, the pharmacist should first consult the Prescription Drug Monitoring Program (PDMP) to assess the patient's prescription history. Next, they should engage the patient in a non-judgmental conversation expressing concern for their health and offering support. If necessary, the pharmacist can refer the patient to a healthcare provider for further assessment or addiction treatment. It's important to document the encounter carefully and follow up with both the patient and prescriber. Law. In California, pharmacists are mandated by Controlled Substances Act (CSA) to check PDMP databases before dispensing controlled substances, particularly opioids. A patient with type 2 diabetes is struggling to maintain optimal blood glucose levels despite adhering to their prescribed metformin regimen. What strategies should the pharmacist implement to support this patient in managing their diabetes effectively? Answer. The pharmacist can employ several strategies. Medication review. The pharmacist should review the patient's current medication regimen for potential interactions, adherence issues, or suboptimal dosing. If the patient has been on metformin alone and is still not achieving target AC levels, the pharmacist can suggest a medication adjustment or addition of other antihypoglycemic agents, such as GLP-1 receptor agonists or SLT inhibitors, based on clinical guidelines. Patient education. Education is crucial. The pharmacist should ensure that the patient understands the importance of regular blood glucose monitoring, recognizing signs of hypoglycemia, and the role of diet and exercise in diabetes management. Providing resources or referrals to diabetes self-management education programs can be beneficial. Lifestyle modifications. The pharmacist can work with the patient to set realistic goals for lifestyle changes, such as diet modifications or increasing physical activity. Discussing the importance of a balanced diet, weight management, and regular exercise can help the patient improve glycemic control. Regular follow-up. Establishing a follow-up schedule allows the pharmacist to monitor the patient's progress, adjust the treatment plan as needed, and provide ongoing support. Guidelines. According to the American Diabetes Association, effective diabetes management includes a comprehensive approach that incorporates pharmacotherapy, lifestyle changes, and continuous patient education. Michael, a 55-year-old male patient, visits the pharmacy for a medication refill. During the conversation, the pharmacist notes that Michael has a family history of cardiovascular disease and is a smoker. His last cholesterol screening was over a year ago. What actions should the pharmacist take regarding Michael's cardiovascular risk? Answer. The pharmacist should take the following actions. Assess current medications. Review Michael's medication profile to ensure he is on appropriate therapy for his cardiovascular risk. If he is not currently taking a statin or appropriate lipid-lowering therapy, the pharmacist should initiate a discussion regarding the benefits of starting treatment, recommend screening, encourage Michael to have his cholesterol levels checked if he has not had them screened in the past year. The pharmacist should explain the importance of regular lipid panels, especially given his age and risk factors. Lifestyle counseling. Engage in a conversation about smoking cessation strategies, highlighting the benefits of quitting smoking for improving cardiovascular health. The pharmacist can provide resources, such as counseling services or nicotine replacement options. Collaborate with healthcare providers. If appropriate, the pharmacist should recommend that Michael schedule an appointment with his primary care provider to discuss his cardiovascular risk factors and potential adjustments to his treatment plan. What specific roles do pharmacists play in emergency preparedness and disaster response, and how can they effectively contribute to public health initiatives during such events? Answer: Pharmacists have several key roles in emergency preparedness and disaster response. Medication management. Pharmacists are crucial in ensuring an adequate supply of essential medications during emergencies. They can help identify stockpiles of medications, manage inventory, and facilitate the distribution of critical medications, including antibiotics and antivirals. Patient education and counseling. During a public health crisis, pharmacists can provide valuable information to patients about managing chronic conditions, understanding medication instructions, and the importance of adherence to prescribed therapies. Coordination with healthcare providers. Pharmacists can collaborate with healthcare teams to develop protocols for emergency situations, ensuring that medication dispensing practices are aligned with the needs of the community. Public health initiatives. Pharmacists can participate in vaccination campaigns, such as during outbreaks of influenza or other infectious diseases, and provide preventative care services, including education on hygiene practices and disease prevention. Jessica, a 60-year-old woman with a history of hypertension, comes to the pharmacy with a new prescription for lisinopril. She mentions that her blood pressure readings at home have been fluctuating and expresses concern about potential side effects. What recommendations should the pharmacist provide to Jessica regarding her hypertension management? Answer: the pharmacist should offer the following recommendations. Medication education. Explain to Jessica how lisinopril works as an ACE inhibitor to lower blood pressure by relaxing blood vessels. Discuss potential side effects, including cough, elevated potassium levels, and renal function changes, and emphasize the importance of reporting any severe adverse effects to her healthcare provider. Blood pressure monitoring. Advise Jessica to regularly monitor her blood pressure at home. Educate her on proper techniques for accurate readings, such as using the same arm each time, resting before taking a measurement, and avoiding caffeine or exercise beforehand. Lifestyle modifications. Encourage Jessica to adopt lifestyle changes that can support her blood pressure management. This includes following a low-sodium diet, engaging in regular physical activity, managing stress, and maintaining a healthy weight. Follow-up and communication. Recommend that Jessica schedule regular follow-up appointments with her healthcare provider to evaluate her blood pressure control and adjust medications if necessary. Encourage open communication about her readings and any concerns she may have regarding her treatment. What are the key components of an effective opioid stewardship program in a pharmacy setting, and how can pharmacists implement strategies to mitigate the risks associated with opioid therapy? Answer: an effective opioid stewardship program includes several key components. Patient education. Pharmacists should provide thorough counseling to patients receiving opioid prescriptions, discussing the risks of misuse, safe storage practices, and proper disposal methods for unused medications. Monitoring and risk assessment. Implement a system for monitoring patients on long-term opioid therapy. This may include regular assessment of pain levels, function, and any signs of misuse or dependency. Utilizing prescription drug monitoring program (EDPS) can help pharmacists track patients' prescription histories. Guideline adherence. Ensure that prescribing practices align with clinical guidelines, such as those from the Centers for Disease Control and Prevention (CDC). This includes prescribing the lowest effective dose for the shortest duration necessary. Multidisciplinary collaboration. Work with healthcare providers to develop comprehensive pain management plans that may include non-opioid alternatives, physical therapy, or behavioral health services. Continuing education. Pharmacists should engage in ongoing education regarding the latest evidence-based practices for managing pain and opioid use disorder.